Welcome, everybody, and thank you for coming to our third session. I'm going to lead us in prayer. And the last time when I was here for the first session, I had to rush out. And so if you have questions that I didn't answer, we can start that way. And then I'll introduce Mike Wargo. Mike is a member of our parish, and he's high up in the governing circles of hospice, and he can really help us understand the directives and hospice. So let's begin in the name of the Father, and of the Son, and of the Holy Spirit. Amen. Lord God, our Father, we praise and thank you for the gift of your Son, Jesus Christ, whose death and resurrection has saved us from sin and death. We ask you, Lord, as we reflect on the whole subject of death and the whole subject of our faith and life after death, to guide us and give us your Spirit through Christ our Lord. Amen. Father, Son, Holy Spirit, amen. So the last time I was here was, I had RCIA last week, or no, we had continuing ed last week. I always forget that. I talked about, the faith issues of death and dying and resurrection. Do any of you have any questions that I didn't answer? I did feel bad because I rushed out, but I had to. Good. It may come up as he talks. So I want to introduce Mike Wargo. Mike's a member of our parish, and he's been working with hospice. In fact, he took hospice to Uganda. So the year that I went to Uganda to celebrate Father Larry's dedication of his church, he was there too. We were there. We were like the only white guys in the whole congregation. It was really cool. But it was quite, and Mike came back grateful that we don't have 4-hour masses here at St. Pius. So Mike, thank you again for doing this.
Thanks, Father Bill. Appreciate that. It was a 4-hour mass, as I recall, and I think we waited an hour and a half for the Archbishop to show up. Yeah, but we got to go over for dinner, and he took a nap, I think, and a bath in between, and we sat out there waited. So it was very nice though. It was hot, but it was great, and I got to sit in the front row because I was with him. It was really awesome. So wonderful. So I know a lot of faces in the room. I know a few names, but I'm happy to see everyone here this evening. I brought along some materials, which I placed in the back of the room, and it appears they've all flown off the shelves. So I'm happy to... Oh, great, wonderful. So I have more that I can send over. We have a whole room full of them. So I'd like to talk a little bit about, first of all, about advanced directives. And discuss some initiatives that we've been working on for several years here in our region that are all around the subject of advanced directives. Then I'd also like to then spend a bit of time talking about hospice and palliative care and try to help you understand and navigate that whole process, which is a little difficult sometimes to figure out what's the difference between hospice and palliative care and what's all that means. So I'll start out with just referencing the fact that those of you who got one of these, and I have more that I will send over, so you will have those. Is there a fourth session next week? Yeah. Oh, good. I'll have more over here.
And also, Stephanie's making more right now.
Oh, excellent. Okay. Very good. So there's a couple pieces you will see in there. One references who would speak for you if you could speak for yourself. And so this is just a very basic rack item that we have. And basically creating your personal plan involves just talking about it with your loved ones, writing it down, documenting it, and then sharing it. And sharing it with your physician, having it available at the hospital. How many have been in the hospital where you don't have to raise your hand, but think about this. How many of you have been in the hospital when they've asked you if you have an advance directive? And you've nodded your head and you said, yeah, I have an advance directive. Did they ever ask you for it? No. Yeah, I know. Isn't that something? It's like, okay, it's good.
Sometimes they have you bring one in and put it in your record.
Yes.
So that they have it at the hospital.
Yes. And that's something that I want to encourage people to do. Once you do have an advance directive, make sure your physician has a copy of it. Make sure the hospital, your primary hospital, if you go to St. Joe, you go to Memorial, wherever it is you go, make sure they have a copy of it as well. They'll put it in your record. And have one in your pocket with you. You know, there's a lot of different ways to get that information out there. So I want to talk about what's called Honoring Choices Indiana North Central. So this is a collaborative effort that we've been working on now for about 10 years with all of the local hospitals. And there's a piece that looks like this. It says, "Are you prepared?" And it discusses starting with a conversation, ending with a plan. And there's a step-by-step process that's related to honoring choices. And we are the collaborative of the hospitals that are involved in this is Goshen Health System, St. Joe Health System, Beacon Health System, and Hospice Foundation. So we're the ones that are helping do that. Hospice Foundation is a supporting foundation for the Center for Hospice Care. We serve 9 counties across north central Indiana. So I give you this because there also is a piece in here. If you'd like to get additional information, you can check some boxes, or you can make a phone call or send an email, and all that information is in here. We actually have trained facilitators. I believe we're up to about 135, 136 trained facilitators who can actually facilitate the conversation with you and your loved ones, your family, about what it is that you want. And whether it's at the end of life or it's just when you're in a situation where you end up in the hospital and who knows what's going to happen. Having that documented is so important, and they can help you do that, or we can help you do that through that facilitation process. There's a couple other pieces in here that describe what is advanced care planning, and it describes what advanced care planning actually is. And those of you who don't have that, there will be some more available, I'm told, at the back of the room. And it just goes through and it describes what all is entailed in an advanced care plan. The next piece is actually the Indiana Advanced Care Directive. And I know you have, we also have some materials here from the diocese that are available that talk about, it's more specific to the Catholic faith. This is the Indiana Advanced Care Directive that we're currently using. I believe it was updated in, do the trombone here, 2022. So very, very recent, very current documents. Very simple to complete. And then located in the little inside flap is the more detailed version of this. And this is the Indiana Advanced Healthcare Directive. There's 3 parts to it. Choose your healthcare representative, make your own healthcare decisions, and then sign the form, and then get it notarized. So it's important to have it either witnessed, and I believe there talks in there about witnessed by a couple people, or having it notarized. This is the more detailed version of that, and this asks a lot of questions. It's, what do you want to have done? What do you not want to have done? Do we want to take one of the pieces that's in here is, I believe, talking about what do you want to have done with your pets? So those are some of the things that we like to help people think through in that process. So this is the self-study version. If you don't want to have a facilitated conversation, this is something you can actually do yourself. And it's very simple, step-by-step guide. But get it notarized. Make sure that it gets to your healthcare providers so that they have it in your record, and make sure that it gets into the healthcare system wherever it is that you go. If it's St. Joe Hospital, make sure they've got a copy of that. So that's everything that's contained in this document. But the Honoring Choices Indiana North Central is part of a consortium of programs throughout the state of Indiana. I think there's 13 now throughout the state of Indiana, and it's based upon the Respecting Choices model that was developed several years ago that a lot of states have adopted, and Indiana has decided that honoring choices is the direction that they want to go with this. So it's kind of some branded materials. So yes, sir. Yeah, it's available online, and you can go to, you can actually go to the Hospice Foundation website, which is foundationforhospice.org. And I've got some business cards here as well, so that would have that information on it. There also is a separate website for the Honoring Choices initiative, and that material, that website is referenced in here as well. So you can actually go there, get all this information online, and then, of course, we can schedule a time to facilitate an actual conversation. We can do that in our office, or we have people who will go wherever it is that we should go. So, other questions about? Yes.
Okay, thank you. Give these copies to the hospital.
Yes.
So I'm not in the hospital, but who do I go to give them to? I just go up to the information desk and say, I've got this and I want to put it on file. Who do I go to?
Okay, so the question was, who do I go to if I want to get this information into my records in the hospital, but I'm not necessarily in the hospital right now and not planning to go to the hospital? I would give it to your primary care physician and make sure that he or she is aware of that. Give a copy to them and ask that they put that into your medical records. So the electronic medical records we used to all be on the same system a few years ago, and so the EMRs were all shared among the hospitals. So if you went to Memorial or you went to St. Joe, we could access that information. Center for Hospice Care was on the same program, and now everybody's on different programs. So it's very difficult, very complicated to get that information from one another. And of course, you go to every time you go into a new healthcare provider, even though maybe it's a South Bend clinic or wherever it happens to be, you're always having to fill out the same forms. Like, I already said all this stuff before. Don't you have that in my record? It's in my permanent record. They still have in my permanent record from St. Vincent's grade school. That my permanent record still has a lot of things reflected in there, I'm sure. Father Bill can probably access it and find out, and he has. That's why I'm here.
They give you about 6 doctors. and
Yeah.
they're not your primary physician. So my personal thing, I'm a nurse, is I could give a copy to my primary care doctor, but I would go to the hospital and have medical records put it in your record.
So here you go. So we have the good advice. So the advice here is to take it to the hospital, ask them to put it to the medical records department, and ask them to put it in the medical records so that that's there on file. A lot of ways to get that information out there, or you just carry it around in your pocket, I suppose. Yes.
Okay, we do all these directions for Northern Indiana. What if you're somewhere else and something happens?
So
Do you have to honor it? Do they not honor it? Or?
well, now you're getting above my pay grade. So the question is, will it be honored or not honored if you're in another state? The Indiana Advanced Directives, the way that this is supposed to work is there's supposed to be there's a reciprocity among other states. If you've completed this, you're in the state of Indiana, you're a resident of the state of Indiana, it's obvious because you have an Indiana driver's license, they should be honoring it. Now, that said, it depends on who you talk to, and it depends upon where you go, because the question that you just asked is a very good one. There's talk about creating a national repository for advanced directives. It hasn't happened yet. There's been talk about doing it here in the state of Indiana. Hasn't happened yet, but it's been in the legislative sessions the last few years to try and get something in place. They do have a program in the state of Michigan, so if you're in Michigan, this won't work. But if you're in Michigan, we can get you some materials. But that actually is also a state that has developed a system where there is a repository where that information can be accessed by healthcare providers. Yes.
If you go to a facility that's doing outpatient procedure, they say, we don't honor. Why? I've been to one that said that.
So the question was, I've been to an outpatient facility that says, we will not honor your advanced directives. I think I'd go somewhere else. Because, you never know what you go in somewhere and you think everything's going to go fine, and it may go a different direction. And you certainly want to make sure that they're aware of what your wishes would be in the event that something did not go the way as planned. So that would be my suggestion.
They tell us that because, they say if anything happens, that they'll take it to the hospital. So that's why they ask.
If anything happens, they will take it. They'll take you to the hospital?
Yes.
Okay. Provided, okay. Well,
I think they gotta honor it. If you have a copy of it with you and take it with you to that appointment, I think they have to honor it. Because if we don't have written, we don't honor it. We have to resuscitate them,
unless they have something that says,
Yeah.
do not resuscitate, yeah. Which also then comes to something that Father Bill will talk about, which is, the faith piece of it. Oh, he's got it in his hand. So Father Bill, do you want to maybe talk a bit we can kind of tag team the advanced directive piece, and you can speak from your piece.
Thank you. And I think all of you have these in your packets. I find this a very, very helpful guide. So, as Catholics, we too can use advanced directives. In fact, I have them. I've put them out already. You don't have to, but you can. And I would just kind of like to walk this through you. Everything that Mike said is in the first part of this. But look at where it says ethical principles, okay? That's on page 5. So I'm just going to go through. These are Catholic ethical principles. First of all, we say human life is a precious gift from God, and it never becomes something to be disposed of. Second, we have a right to direct our own care and the responsibility to act according to the principles of Catholic moral teaching. Third, suicide, euthanasia, and acts that intentionally would cause death by act or omission are never morally acceptable. Fourth, remember, death is the beginning, not an end. That's especially from the perspective of our belief in the death and resurrection of Jesus Christ. 5, there should be a presumption in favor of providing a person with nutrition, food, and hydration, water, even if medically assisted, as long as this is of sufficient benefit to outweigh the burdens involved. That can be a very difficult decision sometimes. So it's, the principle is food and water should be given to keep the person going. Now, I had a situation not too long ago, about a year ago, where the woman, she was 90 years old, and she had ALS, and the doctor said we should put a feeding tube in. And so she and I talked about it. I had her talk to the doctor about it, and she decided not to have the feeding tube. And I supported her in that situation. Those could be the very, very difficult situations. In the 1950s, it was Pius XII who said we have to use every ordinary means to prolong human life. We don't have to use extraordinary means. Well, that's become increasingly more difficult today with all the technology we have. So stop me at any time or raise your hand if you want to ask anything. So that's the presumption. However, situations, if you look down, situations might exist in which this is not the case, such as when a person is no longer able to assimilate nourishment, or when death is so imminent that withholding or withdrawing water and food will not be the actual cause of death, or when the means of providing medically assisted nutrition or hydration is disproportionate to the benefit gained. That's the principle I used with the 90-year-old, who said, I don't want a feeding tube. And I totally supported her in that. But one of the things to remember, we cannot withdraw food or water to cause death. Always remember that, when making the decision. We can't withdraw it if it causes death. Number 6, we have the right to comfort and to seek relief from pain, of course. And I think Mike will talk more about this when he talks about hospice. So a person has a right to pain relief and comfort care, even if the method or treatment indirectly and unintentionally shortens life. However, it's not right to deprive the dying person of consciousness without a very serious reason. Again, those many times, and I get involved in this a lot. We priests get involved in helping people make this decision. And then, what's the difference between ordinary or proportionate means of preserving life and extraordinary or disproportionate means? So that's really the distinction Pius XII made a long time ago. But here's what it says. Ordinary or proportionate means are those that, in the judgment of the patient, offer a reasonable hope of benefit and do not entail an excessive burden or impose excessive expense on the family or the community. A person has a moral duty to use these means to preserve life. So ordinary and proportionate, those are really important terms. Extraordinary or disproportionate means of preserving life are those in the patient's judgment. And so many times we rely on the patient, we respect the judgment of the patient, that do not offer a reasonable hope of benefit, or that entail an excessive burden or impose excessive expense on the family or the community. A person is not morally bound to use these means and may forego them. So when when confronted with these concerns, does the procedure, therapy, or prescribed care prolong one's life, or does it artificially delay one's death? It's a really, really important decision. Because remember, we say over and over and over again, we believe in the sanctity of human life from conception through natural death. And that natural death, is that. And it says, is this all we need to know? No. And again, a lot of times, especially if you have a Catholic physician, or if you need, help, don't hesitate to call us. That's what we're here for. We're not, and again, the next page reaffirms what Mike said. As Catholics, we're fine with that. And if you want to do organ donation, is that morally acceptable? Yes. And then one of the things, I've done this a long, long time ago. I made my directives, and I made it pretty clear that I don't want to be, if I'm in a situation, I don't want that to happen. One of the things I used to say, remember when Father Dan Scheidt was here? I said, Dan, if I have a heart attack, I want you to give me the sacrament of the sick and then give a homily before you call EMS. That fixes him. Any questions? It's pretty clear. Any questions about any of this? And again, I think what this does is to put the Catholic perspective on what Mike is talking about. Yeah.
Your statement here is one question we asked in front of the concerns. Does the procedure, therapy, or prescribed care prolong one's life, or does it artificially delay one's death? My mother had breast cancer. They wanted to put her on chemotherapy. And she said no. Well, on the first person, because drugs you'll get 6 months to 2 years. No, you'll get 6 weeks to 6 months. So, on the first sentence, the procedure would prolong one's life. On the second, does it artificially delay one's death? They're like the same sentence.
You're right. You're right. And that's where those decisions become really, really, really difficult. And again, I know people who, after they've gone through one round of chemo, another round of chemo, they just said, I've had it, no more chemo. And that would be acceptable. Yeah, that's a very good point. That would be.
You wouldn't even have to go, because she was in a room, the woman had the same breast cancer. She was up all night, they gave her the first round, she was up all night throwing up, it was horrible, and my mom said, no way.
Good for her. And I think what we have to do, we who love them, we need to talk with them about it and again, get good medical advice on it, but then ultimately accept their decision. It's true. Yeah.
Father, I'm reading item 3 here, the ethical principles. Suicide, euthanasia, and acts that intentionally would cause death by act or omission are never morally acceptable. How does that dovetail with the idea of a DNR, do not resuscitate? Is that considered an omission?
No. And I was trying to think of that word. I have a DNR in my no, a DNR is not suicide.
It's not considered an omission.
No, it's not. No. A DNR just says I don't want. It's interesting in accidents, the medical people will resuscitate them automatically. I mean, that's just what they'll do, and that's good. But so many times, if there's no hope, then that just prolongs the agony. Yeah, it's that DNR is not an omission. That's not euthanasia or suicide. It's not. Mary.
I have a friend who was on dialysis for years and found at the point, he says, I just can't do this anymore, and was taken off, and of course he died a few weeks later. Is that, how does,
I think that's morally acceptable. It's morally acceptable. Do you know, it's amazing with dialysis. They've come a long, long way just in the last 20 years. I have a friend I went to say, he's another priest, and he does dialysis every night in his own home and has a great attitude. I so admire his attitude. But no, that's acceptable. It is.
I think if the person feels that there's a quality of life after whatever procedure that they're being asked to undertake, that was my mother's decision was based on that. And so when she had the cancer, she said, I will continue with whatever they ask me to do until I don't feel there's going to be a quality of life beyond that point. And so when it got to that point, she had a feeding tube already because of the cancer she had was in her throat and so forth. So when she went into a coma, my brothers and sisters called me and said, Dave, what are we going to do? Will we feed mom through the feeding tube? I said, ask the hospice nurse. And the hospice nurse said, what would your mother do if she didn't have the feeding tube? And they said, she'd die. She said, then that's what is naturally for her.
Yes. And see, those, you always have to take into account those individual circumstances. And if you notice, both in this and in what Mike was talking about, respect the wishes of the patient. As long as the patient doesn't want some kind of euthanasia, it's fine. Respect the wishes of the patient. And sometimes that can be really difficult, really, really difficult, because we don't want to lose them. But natural death is part of life. And I think all of our great medical advances are wonderful, but they just make these decisions more difficult. They just make them more, in 1950, when Pius XII said the distinction between ordinary and extraordinary means, it was really pretty straightforward. But today it's really difficult. Good.
I come from a long line. I've been a nurse for over 60 years. I've been a nurse over 60 years, and when I worked at St. Joe Hospital, the priest rushed in to give last sacraments, and CPR was just coming in, and they just started code teams. So, it was like, get out of my way. So I think we've come a long way, and I think you can change your mind. Just don't think that what you decided one time has to be what it's going to be, because you can, as a patient, you can always change your mind.
And this kind of dovetails, and we'll talk about this more when Mike goes into hospice care, but when to call a priest. Call a priest, and remember, I was trying to make these distinctions the last time. The sacrament of the anointing of the sick is for healing, so it's for any serious disease. And a lot of times if people are having surgery, they'll either come into the office or they'll say, would you anoint me after Mass? And we do the anointing of the sick several times. So, never hesitate to ask for the anointing of the sick. Never hesitate. I remember when my mom was diagnosed with cancer, and I have a lot of faith in the sacrament of the sick. When she was diagnosed, we all went to where my parents were living. We were all sitting around the table, and I decided that, we would do the sacrament of the sick. And there we were all a mess. All of us were crying and sobbing. My mom says, "What's the matter with you? Don't you have any faith?" Oh, Mom. And it's really interesting because I think every single one of us, including me, we're praying for healing. That's what we want, Lord. That's what we want. You know, because remember, a sacrament always does what it says it does. There's always healing. But there's got to be faith too, because my mom eventually did die from cancer. So it wasn't the healing that we wanted, but I could tell it was the healing that she needed as she went through the final months of her cancer. And then the biggest healing was that I was reconciled with a brother that I had been fighting with for years. You know, that happens sometimes. I call him my redneck brother. I love my brother. But my brother, he would never go to college. He never went to college. And he would always make fun of me, you know. He would call me the priesty boy, you know. And I mean, and my mom would make me at Christmas come home. You know, this is before I became a pastor, to celebrate Mass, because she wanted Ed to go to Mass at least once a year, you know. So, and I'll never forget, I decided I would preach at my mom's funeral. You know, I thought, you know, my brothers, my sister, they gave her grandchildren. I'm going to do this. So it was really hard. I'm glad I did it. You know, that's what I've learned about preaching at relatives' funerals. You don't look at anybody. And I finally made it through it. And my brother came up afterwards, you know, and my brother said, "How did you do that?" I said, "Well, that's kind of my job, is my day job, you know." And he had never considered that before. He had never, ever considered that maybe I was doing something valuable as a priest. He had never considered that. And I saw that as, you know, I'm really close to my brother now. He's still a redneck, but I'm really, really close. He's the one I go to his house for Thanksgiving. So the sacrament of the sick, if somebody is dying, that's viaticum. And viaticum means food for the final journey to God. And viaticum is Holy Communion. And again, don't hesitate to call us. If someone is in the process of dying, then call us. You know, viaticum works best when the person can still receive communion. But another thing I've learned, and I've learned it by making mistakes, everything I've learned is by making mistakes. I've learned if somebody calls, go, don't delay, because you never know. So viaticum is food for the journey. And a lot of times when people, you know, when they're not conscious, I bring the Eucharist. I give the Eucharist to the rest of the family and then make the sign of the cross over the person who's unconscious. And if they've died, call us, because those are prayers. We have prayers for the dead. It's a really, really beautiful. With the book that we use, it covers all of those instances. I remember when my dad was dying, my dad took a whole week to die. It was very clear he wasn't going to make it. He was not conscious. And so I was leading the family in prayers. And of course, my brother Ed was there. I was leading my family with prayers. And we kept saying, "Go home, Dad. You can go home to Mom." And he just kept going, because his heart was so strong. Finally, the Holy Cross priest, who was the chaplain at Holy Cross Village at Dujari House, the Holy Cross priest came in, did a prayer, and as soon as he left the door, my dad died. And my brother Ed said, "See what a real priest could do?"
So, if someone dies at home, we call you first, we call 911, even though he is dead.
Call us, and we have a beeper. You know, only drug dealers and St. Pius priests have dealers. But and I have to confess, as I've gotten older, I give it to Father Augustine. But what that does is it filters out, you know, all the calls. So we have an answering service, and if it's a real emergency, they'll call the beeper. Yeah, call us, and then call the funeral home. Call the funeral home. So yeah, it's one of the things, again, I've learned, one of the most important jobs that we do as priests is to minister to the dying. And so many times you get water, you do the prayers, you just sit there. You know, it's just the presence.
If your spouse is already with hospice, you call so the nurse can come.
Yeah.
And declare, and then you do the funeral and
Yeah, that's right.
the priest.
That's right. If they're in hospice care, the hospice nurse will say, yes, this person has died, and then call us. I had a death not too long ago. The guy was really a good friend of mine, and he had died like at 7 a.m, and they called me about 8 or 8:30 or so, and they just wanted to sit around with the body for a while. So I went and we did prayers, and I just think that's really important.
I think it is too.
It is.
When you go to that funeral home, if they have to wait around, they get very impatient.
You're right.
I worked in pediatrics a lot of my career, and those people, even though they had signed, do not resuscitate because that poor child had gone through so much in its life already, they needed to hold her and
Yeah.
say goodbye to her while she was warm and
Right.
still the child that they remembered.
That's right.
Not in the funeral home after she divorced.
That's right. That's right. Yeah, that's right. A lot of people want to stay around while the body's still warm. That's a good point.
And the supervisor's coming up there and saying, oh, the funeral home's getting antsy, they want to take her on. I said, they're gonna have a chance to say goodbye. They took care of her for like 4 or 5 years, and she was sick ever since she was born, and all that love it takes.
That's right. People need time. They really do. Okay, Mike. Oh, wait, Mary.
Question, I don't know if you know the answer, but all right, if someone dies at home, then you said call you and then call funeral. Do we call funeral, or do we have to call a medical professional? Do we have to call 911? Do they have to pronounce the person dead?
Well, a lot of times, to be honest, no. A lot of times what happens is people will call me and then say, which funeral home would you recommend? And I'll give them, a list of funeral homes that we use at St. Pius. So sometimes that does happen where they just aren't prepared for the death. They're just not prepared, and we can give them recommendations.
But I mean, it's okay just to call the funeral home without having somebody officially say?
Yeah.
they
Oh,
died?
yeah. Oh, yeah. You can do that.
Okay.
Yeah. But again, and you're right, if they're in hospice care, the hospice nurse will help you. And I just, before I give it over to Mike, hospice, if you've not had any dealings with them, they're wonderful. And the new facility that you have on the river is just incredible, and hospice, the beautiful thing about hospice is hospice says, death is part of life. And when there's no opportunity for healing, we're there to help you through it. With hospice, you can go in anytime. I love the hospice nurses. It's just, you tell them about it. Okay, Micah.
And my son turned out to be a hospice nurse.
Oh, that's great. Wonderful. I don't know how I follow that, but thanks, Father Bill. So I'll talk. Thank you. So I want to spend a little bit of time now talking about hospice and palliative care. There's another piece that some of you may have picked up. This is our generic brochure. It tells a little bit. We have so many brochures. I mean, it's like coming to St. Pius. There's all the racks full of stuff. This is kind of the overview piece, and just describes hospice and palliative care in general. It talks a little bit about our organization. Center for Hospice Care was one of the first hospices, if not the first, in the state of Indiana, founded in 1978 by a group of concerned community folks who decided that this was a good thing to do. And it started as a movement in England back in 1967, and then through the years it came to the United States. And in 1974, the first hospice program was established in Connecticut, New Haven, Connecticut. And then from there, it started to spread around the country. And Elizabeth Kubler-Ross, you may have heard that name, actually went around the country and spoke about the benefits of hospice care. And so a number of organizations ended up starting up throughout the country. So we started seeing patients in 1980. We served 27 patients and families that year. And by the way, I like to talk about the unit of care. It's not just the patient, it's the patient and the family, the loved ones that surround them. That's our unit of care, and that's who we're focused on, is trying to make sure that they are all comfortable and understanding everything that's going on along the way. So we had 27 patients that first year, and then through the years, we've now served over 35,000 patients. I take that back. This is my old speech. This was when we did this a few years ago. It's closer to 45,000 patients now that we've served and their families through the years. And so one of the things that that people don't quite understand is this difference between hospice care and palliative care. So palliative care, if you think about a broad term, like picture a big circle, and palliative care is the broader term. And hospice care is a very specialized form of palliative care. And it is designed to, according to Medicare gets to decide all these things. The Medicare hospice benefit, somewhere in Congress, they decided that this was that if you are diagnosed with a disease or an affliction or something that will likely take your life within the next 6 months, well, you're eligible for hospice care under the hospice Medicare benefit. If it's 6 months and 1 day, you're not eligible. You got to wait another day. So what has to happen then is you have to have a physician who would determine that he believes in his or her best judgment that if this person, if this disease runs its normal progression, its normal course, this person will likely die within 6 months. Now, we have people who graduate from hospice care along the way. They get better along the way. Interestingly enough, part of that we've figured out, and there are studies that prove this, is that people sometimes are just lonely. They don't have anybody to take care of them. No one's paying any attention to them. And as they're dying, people start paying a little bit more attention. And then hospice gets involved, and then we're making regular visits. We're out seeing them. The physicians are coming to the house. Nurses are there regularly. We have social workers that are coming and sitting and visiting and engaging family members and helping family members understand the process and getting them re-engaged. And oftentimes, we'll see people that will actually they will graduate from hospice care. In other words, a doctor will say, I don't think this person's going to die within 6 months. And so we're going to kick them out. Now you come back, a little bit later. And Dave is nodding his head. You've got one of those right now. Oh.
The guy was getting better as I kept visiting him, and the nurse kept saying, I don't think he's going to die. They had to go and break it to his nurse. She was upset because it was going to cost her money now to have somebody care for her.
Well, Dave, if you came to visit me, I'd probably get better too. So anyway. So hospice care then is this artificial amount of time of 6 months. And the way that hospice care gets paid for is through there's 3 or 4 different payer sources. One is Medicare, the Medicare hospice benefit. If you're 65 or older, and there's a couple of you in the room that meet that criteria, the Medicare hospice benefit will take care of you, and will take care of paying whatever it costs for hospice care. And people say, well, how much is this going to cost me? It's like, well, you have Medicare? No. You have private health insurance? Yeah, okay, well, you're good. If you have private health insurance, or you are eligible for Medicaid, or are in the Medicare program, it's all paid for. It's 100%. I don't say it's free, but it's basically it's paid for by the government or by health insurance providers. What happens if I'm not old enough for Medicare, not poor enough for Medicaid, and don't have a private health insurance? You kind of fall into a gap, and the gap is has a very generous sliding fee scale, because we have to do means testing, because we accept money from the government, so we have to make sure that everybody's paying their fair share if they fall into any of those categories. But we have a means testing process, and so we'll go through that, and it almost always guarantees 100% reimbursement for the services we provide. And we do that because we're able to do fundraising, and people who give to our program, a lot of that money goes toward patient care, unreimbursed patient care, discounted patient care. It also goes toward bereavement services, the things that we do for patients and the patients' families. It's the only thing, one of the only programs that has that's a Medicare program that requires you to do something after a patient's death, and that is for 13 months after the patient's death, we're obligated to provide bereavement services. Now, some providers, and just so you know, there are 32 hospices operating in our 9-county service area. We serve 9 counties across north central Indiana. There are maybe 3 or 4 that are nonprofit organizations, and we all pretty much subscribe to that same philosophy. And then the others are for-profit hospices, and I don't begrudge anybody making a profit. I was in the for-profit world for many years before I got into hospice care. But I do think that the services that we provide, while they're very good, we do also provide that discounted unreimbursed patient care for people that kind of fall into the gap. So I would also tell you that as we think about palliative care then, what does that mean? Well, palliative care then is, I'll call it comfort care. It's care that we provide for people who are not in that 6-month eligibility. They might be 12 months, it might be 2 years, might be the situation we were talking about earlier where a person is diagnosed with something that maybe it's 6 months to 12 months, 12 months to 24 months, 3 to 5 years, but they're living with pain, they're living with chronic illnesses, things that their physicians can't necessarily manage because they're in the business of being a general practitioner. They can do certain things. Then there are specialists who can do certain things. But then our specialists are hospice and palliative care physicians. So they're actually trained in working with people who are in that type of situation. They're either they're getting closer and closer to the end of life. And so we have 3 physicians on staff. We have 3 nurse practitioners as well, and then we have a whole bunch of nurses and wonderful caring people. We got a bereavement program that has, I believe we have 8 or 9 bereavement counselors. Some are based in Mishawaka. We have offices in Plymouth, in Elkhart, and also in LaPorte, and then of course here in Mishawaka. We have 2 inpatient units. So I'm going to talk a little bit about the difference between caring for patients in their home versus caring for patients in one of our inpatient units. I get calls from people. In fact, I got a text message about 7 o'clock this morning from a gentleman that I've known for a few years, and he said, do you have a few minutes to talk? Well, I always know what that means. So I'll pick up the phone and I'll give him a call. And it's like, well, here's my situation. I have a grandfather. He's 96 years old. He's in the hospital. And they're saying it's probably time for hospice care. And so I said, all right. He said, what do I do? Very simple. If you live here in the 9 counties across north central Indiana and you happen to be here at the time, don't call us from Florida and call 1-800-HOSPICE because you'll get a hospice program down there. But if you call 1-800-HOSPICE, you'll get us. And it goes into whoever came up with this idea was a genius. Somebody came up with the idea that if I take 1-800-HOSPICE and I sell that number to people in certain areas of the country, and I work with the carriers to make sure everything gets routed to them, he gets to make money off of that. And so that's been replicated all over the country. But if you're in our 9-county service area and you call 1-800-HOSPICE, you'll get us. So what ends up happening then is a person will make that call. It'll go into our referral specialists. One of our referral specialists will answer questions. They'll ask a lot of questions, but they'll answer some questions. That person then will, you may just be looking for information, or you may be here to make a referral, which begs the question, who can make a referral? You can make a referral of yourself. You can make a referral of a family member. Your physician can make a referral. Sometimes if you wait for the physician, any physicians in the room? Okay. He will verify this. If you wait for the physician to make the call, it might not happen soon enough. And sometimes that's the case because sometimes physicians don't necessarily want to have that conversation. It's hard to have that conversation. Now, you would have that conversation. No, I know you will. But I do believe then that there are people who have physicians who do have a difficult time having the conversation. And if you know it's time to maybe make that call, do so for yourself, for your loved one, and at least have an assessment done. So what we do then is we send an admissions nurse out. We might come to a home, might go to an extended care facility, it might be in a hospital. We'll do an assessment, and then there's a whole checklist of things they'll go through to determine whether or not a person is eligible for hospice care. I can tell you that almost always they are. If they get to that point and they make that call, almost always they are, but not always. But almost always, we'll say. So that is that's that process. So the admissions nurse then, once they've determined that this person should be admitted, then there's an interdisciplinary team that's made up of a nurse, a social worker, a spiritual care counselor, chaplain, and a home health aide, a physician, possibly a nurse practitioner, and a volunteer, and a bereavement counselor. So that group then, that becomes the team. I know it's a lot of people, isn't it? That team then works together to come up with a plan of care based upon what they're learning from the family and learning from that patient. And they'll put together a plan of care, and that plan of care may be, we're going to get you out of the hospital and we're going to get you home because that's where you want to be. And we're going to take care of getting durable medical equipment installed, whether that's a hospital bed, oxygen tanks, whatever it is we need to provide, prescriptions that relate to the terminal diagnosis. So all of those things are things that fall under that hospice benefit, and we take care of all of that, make sure it's all set up. And then we also will transport the patient to the home or to the extended care facility, the nursing home, to their children's home, wherever it happens to be, or possibly to one of our inpatient units. So our inpatient units, we have two. We're the only hospice program in this region that has an inpatient unit. We have a 12-bed inpatient unit located, one that Father Bill referenced, the Ernestine M. Racklin House, which is located on our Mishawaka campus. By the way, if anybody's ever interested in a tour of any of our facilities, don't hesitate to call me. I'm happy to arrange it. You just come over and we'll bring a group. We'll have an outing. We'll have coffee and donuts, and then we'll go on a tour. But I'm happy to do that so you can see the facility. And I'm going to tell a quick story here in just a minute about why I think that's really important that people get that experience early on. So the Ernestine M. Racklin House, 12-bed inpatient unit, and then we have a 7-bed inpatient unit in Elkhart called Esther's House, which we opened back in 2008. And so both basically the same type of facility, different settings, but you're going to get the same kind of care. So let me talk a little bit about what it means to be coming into one of our inpatient units. So let's just say we have on census today, we'll call it 100 patients. Well, we'll call it a couple hundred patients. And out of 200 patients, we may only have 3 or 4 or maybe 5 or 6 of them that are actually in one of our inpatient units. The rest of them are out in a home. They're in their, wherever it is they call home. It could be an extended care facility. It could be their own home. It could be their children's home. And so the inpatient units are really designed for one of 3 purposes. One, and this gets talked about in here as well, so you'll get to read about this, is there's symptoms that we just can't manage effectively in the home setting. We've got to get them into a place where we can manage those symptoms effectively. Whether it's the pain, perhaps it's diarrhea it can't be controlled. It's just a variety of things. And so we will bring them there with the idea that maybe we're going to be able to return them to wherever it is they call home. And a second reason would be families going out of town, the primary caregivers have an event somewhere, they'll be leaving, they have nowhere for their loved one to be, and so we have what's called respite care. And under the Medicare hospice benefit, and this is something to keep in mind, under that benefit, it's automatic that you get 5 days of respite care. And that could happen more often. It doesn't have to happen just one time. It could be more often than that. And so if a family is just exhausted, they can't handle it anymore, they've really got to have a place for that person to go, that's a valid reason for them to come into one of our inpatient units. And then the other one is when people are coming from a hospital, we don't necessarily know what everything that's going on with them, and we maybe have to do a little bit more of a detailed assessment. So we may bring them to the inpatient unit to be able to do that and figure that out, with the idea that we'll come up with a plan of care. Did I miss anything, Dave? Is that?
I would say to the 11th hour, when a patient is ready to die and
Yeah.
everybody knows it, sometimes it's easier to care for them at the
Yeah.
House or the other Elkhart. They're both very nice facilities.
Thanks for mentioning that. The 11th hour is the term we use. And so if we have someone who, and in fact, this is where my story is going to come in. So we had a situation last Thursday. I got a phone call from a person that I've known for years, and said that his father was at a point, it was at St. Joe Hospital, and he really wanted to stay there and die there. And of course, I asked a question, a few questions along the way, and but he said, we want hospice care. We want you guys to come out. What's the process? So we made arrangements, and we went out and did an assessment. And certainly one of our physicians, and we have two Catholic physicians on staff, very Catholic physicians, and one of them said, I'll go out, and I'd like to go meet this person. So he actually went to the hospital to help with the admission, which was very unusual, doesn't happen very often, and convinced this patient to go home. And because the family really thought that was a good idea, and went home. And that was a good thing for the family. It was a good thing, I think, for him. And then Thursday, that was Wednesday. I take that as Wednesday. Thursday night, we went out, and about 9:30 that night concluded he probably needs to come to Ernestine M. Racklin House. Family was all on board with that as well, although they'd never been there before. And this was a very large family, very large Catholic family. 25 or 30 people showed up at the Ernestine M. Racklin House. None of them had ever been there before. And it was this like an epiphany of sorts. They got in there, and it's like, why didn't we come here to begin with? This is amazing. And they were kind of pushing that away. We don't really want to do that. We don't want them to go to a facility, if you will. And the way that we designed this facility, the way we've designed this inpatient unit is in a way that is respectful of families, respectful of the patients, that we provide space for the families to gather, families to get away from each other, place for the teens to go, place for the little kids to go, and lots of things that just will help them be able to get away and cope. And then places for the families to be able to gather. And we have multiple places like that in that particular location. And we have very similar, but on a smaller scale, in Elkhart. So I went over to visit on Friday. So they were there came in late Thursday night. So I went over to visit with the family on Friday. And I got that feedback. It's like, we had no idea this is where we were going to be going. This is working out. This is great. And so over the course of the weekend, then all of the family got to come, and the question was, why is he hanging on? What's he waiting for? And it's amazing, and Father Bill sees it all the time. But they're waiting maybe to see the other family members who didn't get here yet, and some were traveling from outside the area, and it was a matter of hours from that time after he saw the last person. And he was unconscious, but knew that they were there, felt that presence, and can hear, when people are speaking to them. So I think that for that kind of a facility, that kind of a place for people to be able to go at the end of life is just so important. We're so blessed to be able to have that in our community, and it's thanks to the support from Ernestine Racklin, her name's on the building, but so many other people who donated to make that a reality. And we've now been there, I think we opened in 2020. It was a great time to open, 2020. I mean, just perfect timing. So I wanted to just kind of share that story because people don't know. So if you're interested in coming, I am sincere about this. Please let me know. I'm happy to provide a tour. The other thing that we have, I'm just going to mention, this 6-month thing that we talked about, 6 months, can anyone take a guess at what our average length of stay is on a 6-month benefit? Average length. You don't count. 8 months? 3 weeks? 2 weeks? So I'll tell you, our median length of stay used to be 17 days. Then it went to 16. Then it went to 15. Then it went to 14. We're now at 7 days. Median length of stay. So half are gone before that, half are gone after that. The average length of stay runs around 80 days. It's run between 70 and 90 for several years. But there's some of the people that are there for 8 months, they kind of make that kind of top that out. But nationally, that is also the trend. We're seeing the median length of stay are going down. And we haven't quite figured out what that's about yet, but we think that a lot of it is hesitancy to make those calls. We used to track a statistic. We had one of our folks who retired about 3 years ago. He used to track the statistic for about 7 years, and he's called it DBA. It's deaths before admission. And these are the people that we would get a phone call, but we couldn't get there. And we admit 24 hours a day, 7 days a week. We could not get there before they died. And that number was at 12% at one time because people just wait too long. 10%, 8%, got down to 8%. I think it's probably back up around 11 or 12% again. The most frequent length of stay is 2 days. And it's been the most frequent length. I've been 26 years working with Center for Hospice Care. 2 days has been the number every year. For whatever reason. And it goes back to, call us. Just when in doubt, just make the call. And the worst case will tell you don't qualify.
When you say 2 days.
Yes.
Is that 2 days in 2 days in the program?
That's 2 days in the program. That's 2 days overall. Yeah. Yes, sir.
You talked about palliative care.
Yes.
Where does that fit in with benefits? You said Medicare takes care of all that.
Yeah. It takes care of all the hospice care.
Right. That's what I'm saying.
In your,
Palliative, where are we talking?
I'll tell you, in this little piece that we've got, it describes something, and it provides some information about palliative care, and it talks about the fact that a lot of insurance, will pay for some form of palliative care. They'll generally pay for an initial consultation, but a lot of times it's a matter of what your insurance provider will pay. Under Medicare, there is some provision to pay for consultations, but it's when you're managing chronic symptoms, and then we're able to do that. We're able to bill for that, and then Medicare will pay. But it has to be. There's certain criteria. This talks a little bit about that. And if I go any further, I'm probably stepping outside of my comfort zone. So I can make stuff up for you later on the side. But yes.
My father was in palliative care back during COVID, and him and my mom were in a assisted living facility. And my dad was having a heart attack in the middle of the night. So the staff at the facility where they were living called my sister instead of calling. Should they have called hospice instead?
Yeah. Yeah, I think they probably should have made a phone call to us. Yeah.
They ended up, even though he had the DNR, my sister was kind of, drowsy at the time. And
Yeah.
I asked her if they should do a resuscitation, and she said, yeah, but he had a DNR, and she wasn't thinking about that, and they had to shock his heart 3 different times.
Oh my.
But he survived, and the next day in the hospital, he's sitting in the bed, he looked like Lazarus, I swear to God.
Oh, wow.
About another 6 months, so.
That's great. Well, it worked the way it was supposed to then in that particular situation.
But normally they should have called.
Should have called and made the phone call. Yeah. So we have a triage department that answers calls 24 hours a day, 7 days a week. They make determinations as to what should be done, and almost always we're going to send somebody out to see you. Middle of the night doesn't really matter. We have nurses that are working. We have nurses that are on call, and so we'll send people out if there's we have a couple different specialty programs. One's called HeartWise. Another one's called Breathe Easy. So people with congestive heart failure, HeartWise. People with advanced COPD, Breathe Easy. people who are on those programs, and we have a certain regimen and protocols that we follow. We have special training we do with our staff, and the people that are in those programs, the hospital readmission rate has gone down significantly. And we've tracked that information now for about 6 years, and we're running at about a 98% success rate of no more hospital readmissions. We tell people, don't call 911, call us. We're your 911. And so we come out and we take care and manage those symptoms. But people think they're having a heart attack. I don't know anybody. I'm not going to ask if you had a heart attack. I had a heart attack, and along the way, it's like, of course, I drove myself to the hospital. I know it's a really great thing to do, right? So for me, I think about that, and I don't know where I was going. Where was I going with that? I don't know either. I had a point to make. Oh, I should have. Yeah, but the thing I want to mention though is when people who are in that situation, you got to call a doctor. Call 911. I know where I was going now. For people who have maybe had a heart attack, and maybe they're in our HeartWise program, and the family thinks they're now having another heart attack. Maybe they are, and maybe they're not, because. And I've been down that path, and I've thought I was having a heart attack because it was the same symptoms. And you know what? It wasn't. It was just my body my mind remembering how my body was feeling, and we could take care of that. So we can get out to the house and we can address those symptoms. And if we need to call in a physician, we've got physicians we can bring in, or we'll send them to the hospital.
I was always under the impression, I guess I've had the wrong impression all my life, that hospice is like last minute type thing, because I've had 3 or 4
Yeah.
relatives who were signed up to go to hospice, ready to go, and died before they got there.
Yeah.
So now you're saying they can be there for a time, so who makes that, how do you decide? I know you guys come in and say, no, we can't take you, or do
Yeah.
anything, but
So.
how do we know?
We never know for sure, but if a physician believes that a person has an illness that will likely take his life within 6 months, that's the person who's eligible then for hospice care. We come in to help with that assessment, and our medical director will also look at that and probably talk to the physician that made that referral, just to make sure that they're on the same wavelength. And sometimes people think about, if I go into hospice care, does that mean I have to give up my regular doctor, the doctor I've gone to for years? And no, that's not the case. You can continue to have your other doctor be, kind of your general, but the hospice doctor becomes then the person who's dealing with your end of life issues. Which brings up another point that I want to make, and it relates to children. We're talking about pediatrics and the child who passed away at 5 years old. We actually have a pediatrician on staff who's also a hospice doctor. So we're the only hospice in the region that works with pediatric patients. And we take them all, and those are complicated and those are expensive, but we take those cases on and are happy to do so because we have the staff to be able to do it. And I have staff that are actually trained in how to work specifically with children. But there's a benefit that was introduced just in the last few years. Formerly, parents had to give up hope to take hospice care, and if you elect hospice care, you're basically foregoing any other medical treatments. If a child is under the age of 18, the new program is that you can have concurrent care, and concurrent care is pursuing curative care, but also having the benefit of hospice care and having us work alongside them. Our goal, of course, is, in that case, let's get them better. But the reality of it is we're there then for anticipatory grief counseling that happens along the way as well for the family, and also then treating the symptoms of the child. Yes?
Yeah, my neighbor across the street died on Saturday, and she was in your hospice care. The guy, the husband, she had stage 4 pancreatic cancer, and they had come over 3 months ago, 2 months ago, to say, to let us know we were the only people around to do. And he was very complimentary of all your services, and he says, yeah, the hospice people, but he also said the visiting nurse people came in and stuff. So, do they,
So we'll, in our plan of care, we'll make a determination as to how often that particular patient maybe needs visits. And a lot of it depends upon if they have a family member or a caregiver who's there with them regularly, or if that caregiver maybe needs a little bit of break, and maybe it's every Wednesday afternoon from 1 to 3, they need to go somewhere. Then we have people like Dave and other volunteers. Any other hospice volunteers in the room? Okay, we've got one. We could have 60, right? Okay, but anyway, so it's so we'll actually have volunteers that'll come and spend some time as well, and it might be 2, 3, it might be half a day. In Dave's case, it might be a week. He just goes and camps out, but they're there to take care of giving a respite for that person. But then we also will come in, and if we know that baths are not something that the caregiver is able to provide, we may have people coming in more often than that. Our home health aides may come in to bathe them. And then nursing visits. Some cases, the patient may need a nursing visit once a week. Some cases, they may need somebody there 3 times a week. And we may need to adjust medication levels. We may have a physician or a nurse practitioner who makes a call that comes out to figure things out. If it gets a little bit more complicated, we have social workers who will come out and make a call. And for people that don't really necessarily have a Father Bill around, we have chaplains. And we have a number of chaplains that are on staff as well. And we're a non-denominational organization, but we have people of all faiths. And so we're able to take care of people from all faith traditions. So that's might be some of those folks coming in and out. Yes. Yeah, exactly. Yes, but there are people who may elect to have another company come in, a home health care agency, like a Senior One Care or something like that, to come in and actually be there maybe 24/7. But we're also there to take care of managing symptoms. Yes.
Volunteers that
Oh.
come in when people are actively dying, but they don't have somebody to be with them when they're dying.
Yes.
Because one of the people from my parish is that.
Yes.
And I didn't know if she was with your hospice or another one.
Could be 11th hour volunteers, people who come out, and the question was, do we have people who can come and be with people who don't have anybody? And yes, we have volunteers who can come out and do that.